So this week we're going to be talking about lot quality assurance sampling, and I have to say this is a design that is very near and dear to me. I used this design very frequently when I was in graduate school for my research. It's one that I think is very user-friendly and very practical for Ringquavu and for Rwanda and for public health. So we're going to be talking about a particular study that is from the Partners in Health program in Malawi, looking at data quality of community health workers. So the goal for today's session, we'll be talking about what is lot quality assurance sampling. You'll see that abbreviated in my notes as LQAS. So what is an LQAS study? What is the strength and limitation of using this method? And then to discuss the article on data quality assessments of the Community Health Worker Program in Malawi. So first of all, what is lot quality assurance sampling? It is a special kind of a cross-sectional study. So remember, we've talked about 3 different observational designs, and LQAS is a special type of a cross-sectional study. What is a cross-sectional study? In your own words, it's one point in time. And you can look at multiple exposures or multiple outcomes, as Pierre said. But really the feature of a cross-sectional study is it's like taking a photo. It's one point in time. I'm going to go into my population and randomly choose some people and look at what are their outcomes and what are their exposures at that point in time. So even though it is a cross-sectional study, what you'll find is that the design and the analysis of LQAS is different than what I'm going to call traditional cross-sectional studies. So usually when we talk about cross-sectional studies, we think about the demographic and health surveys, or we think about the STEP surveys. We think about these big cross-sectional surveys where we aim to estimate things at the end of the study or look at relationships. However, for LQAS, you will find that the design and the analysis is different, and so even though it is a cross-sectional study, it's going to look a bit different than when we talked about cross-sectional studies before. So I want to just describe to you how is a traditional cross-sectional study and an LQAS study similar and how are they different. So for a cross-sectional study, at the end of the study, we would be able to estimate the prevalence of exposures and outcomes. So what proportion of people in our population have HIV? What proportion of people in our population use contraceptives? What proportion of people in our population are sexually active? And then we would also be able to look at relationships. So what things are related to being sexually active? What things are related to using contraceptives? And we would use, as Pierre said, the multiple outcomes and multiple exposures to try and understand relationships between different factors. How that is different from LQAS. So for LQAS, our goal is to classify. So instead of saying what proportion of our population is using contraceptives, I would say, is contraceptive use high or low? So I'm not looking for an estimate. I'm looking for a classification of high or low, or acceptable and unacceptable. So I'm not trying to estimate, I am trying to classify. So typically what we call traditional cross-sectional studies, typically we think of them as an estimation procedure. I'm going to try and estimate the outcome or estimate the exposure or estimate the relationship between the outcome and the exposure. How LQAS is different is it is considered a classification procedure. I want to classify. I want to put things into groups. Is this area good or bad? Is this area high or low? Is this area acceptable or unacceptable? So So let me show you an example of a traditional cross-sectional study and an LQAS study. So in a traditional cross-sectional study, if I'm talking about the use of bed nets, I would come in and I would say the proportion of children sleeping under a bed net is 55.2%. And remember, we no longer look at the estimate, but we have to look at the confidence interval. So it's 55.2%, and the confidence interval is from 50.2 to 60.2%. This is what I would call an estimation. What we would traditionally do with an LQAS study. Alternatively, I could say bed net coverage is low. So this is a classification. What I would typically do with an LQAS study. So just looking at the results that can come from one versus the other, why do you think that I might prefer an LQAS study over a traditional cross-sectional study where I'm trying to estimate? What would be the benefit of classification over estimation? One benefit is it's already standardized. And we'll actually talk about standardized tier levels. We'll talk about in a few slides how do you tell it what levels you want it to be standardized to. What would be another benefit of classification? So it gives you a clear understanding of performance. The reason why clear understanding of performance is important is, let's say I have 100,000 bed nets to distribute, and I have to decide where to send those bed nets. It's a little bit difficult with this to know, is 55.2%, is that good? Is that bad? Do I need to prioritize? Are they okay? Versus if someone comes to me and says, bed net coverage in Southern Kayonza is low, then I know I need to send resources to improve it. So it gives you a clear understanding of performance. And this can be actionable. So if things are bad, I know I need to do action to make it better. If things are good, I know I need to go in and understand why are things so good there? What are they doing different than other areas? So generally, classifications, you can react to the classification and either give more resources to improve or go in and do a best practice understanding of what is going well there. I think it's easy for decision makers to understand. Both for understanding and interventions, exactly. So a lot of times when I think about I'm doing research to inform programs and to help programs know where are they strong and where do they need to improve, a lot of times I will recommend LQAS because it's very actionable, it's easy to understand, it's easy to go in and make changes based on what you observe. Now there are some drawbacks to having classification where I would prefer estimation. One is if I want to know how many bed nets I need to order, so I need to have a procurement, it's very difficult if it's just low or high to know exactly how many more that I need to improve. So if I need exact numbers of how many more bed nets do I need to order, then I probably need an estimation procedure. Okay? So this one is better for informing procurement. And it's actually better for looking at relationships between exposures and outcomes. So here I said that bed net coverage, the estimation procedure is better for looking at relationships between exposures and outcomes. So it is possible that I could have in my classification bed net coverage is high or low, income levels are high or low, but it's hard for me to know, is income related to bed net coverage based on the classification. But if I have an estimation procedure, these relationships are easier to explore. It's not that it's impossible to do with LQAS, but it's typically not what it is designed to do. So why classification? These are just the points that we talked about. Classification can be linked to a program response. We can shift resources to areas with unacceptable coverage, or we can do best practice studies in areas with acceptable coverage. And ahead of this, the manager should think about what are our thresholds for good and bad. So we talked about having these levels of performance, and that the LQAS classification helps us understand where we are in relation to those levels. So ahead of that, Nadine has to tell me what is her definition of good. What is that level she's striving for in whatever she's trying to measure? And what is her level of bad? What is she not wanting to see that she would be worried about? And secondly, ahead of time, they really should be thinking about the so what. So I go in there and I find that bed net coverage is low. So what? What am I going to do if I see that? I find data quality is low. So what? What will be my action afterwards? And so in order to really use LQAS effectively, it has to be designed with program managers to meet whatever the goals for their programs might be. So you might be thinking, how do I do these classifications? And the process is really quite simple. When I talk about an LQAS system, there's two parameters. The first is the sample size, and the second is the decision rule. So different questions, different research will have different LQAS systems that will have a sample size and a decision rule for that system. So with the sample size and decision rule, this is how I do the classification. So I randomly select my sample size from individuals in that area. And remember, this is a cross-sectional survey. So I close my eyes and I select my N individuals to be included in the study. I count the number with the trait of interest in that sample. So I randomly choose 100 children, and I count the number of children who sleep under a bed net. And I compare that number to my decision rule. If I see that many or less, if I see less than my decision rule, then I classify the area in the low category. And if I see more than that, I classify the area as in the high category. So I have some decision rule, and I count the number in my sample with a trait of interest. And if I have fewer than the decision rule, I classify in the low area. And if I have that many or more, then I classify in the high area. So it is a very simple procedure to implement. So let me just give you an example. We're going to look at the level of bed net coverage. So ITN is insecticide-treated bed net. The level of bed net coverage in children under 5. My sample size is 19, and my decision rule is 9. So these parameters here, this determines my LQAS system. I randomly sample 19 children, and I count in the 19 how many slept under a bed net. If 8 or fewer, so less than 9, if 8 or fewer had slept under a bed net, I would say bed net coverage is unacceptable. If 9 or more of the 19 had slept under a bed net, then I would say that bed net coverage is acceptable. So here's a study where we actually looked at bed net coverage. It was in Eritrea. And in each of these areas, I sampled 19 children, and I looked at the number of children sleeping under a bed net. So in Forto, I sampled 19, and I observed 7 children sleeping under the bed net. I compare that 7 to 9, and it's less than 9, so I say it is low bed net coverage. What would I say about LQAS? I sampled 19 children, and 17 of them slept under a bed net. Is it low or high bed net coverage? High. What about Galuge? High. We did not have data for, I don't know how to say that, DA. So this one is low. Agudots, Gong, Mogolo, Haikota, Burnettu, high. Now remember, every system will have a different sample size and decision rule. So this was a sample size and decision rule that we used to look at the level of bed net coverage. So sample size of 19, a decision rule of 9. We did another study where we were looking at knowledge levels of HIV transmission. So do they know that HIV can be transmitted through unprotected sex? Do they know it can be transmitted from mother to child? And in that study, we used a sample size of 19 and a decision rule of 13. And then we also did a study where we looked at data quality of registers in an HIV program in Malawi. And in that one, our sample size was 76, and our decision rule was 71. So you can see that your sample size and your decision rule depends on your question of interest. So you will have different sample sizes and different decision rules depending on what you are looking at and what the program manager says is their level of performance they're trying to achieve. So where did the 19 and 9 come from? Where did the 76 and 71 come from? So the design of an LQAS system, of the most simple version of LQAS, which is what we're going to focus on today, it depends on 4 parameters. One is what Daniel just said, which is what is your definition of high or acceptable? What proportion of children do we need to see sleeping under a bed net to say that we have good bed net coverage? On the flip side, I also need to know what is your definition of low or unacceptable? So at what level of bed net coverage are you going to be really concerned? Where are you going to worry that you did not have good enough bed net coverage in your population? So what is your definition of high and what is your definition of low? Now remember, no system will be perfect. It's actually not true. There's one way that I know for sure. What's the only way I can know 100% sure to have a census? And here we're talking about samples. So the other thing I need to specify is how willing am I to make a mistake? It is not a perfect system. The only way I could get perfect classification is if I have a census. So if it's not perfect, how willing am I to make a mistake? And there are 2 possible mistakes. One is I make a mistake and I call it low when it is really high. So I'm at that upper threshold, I'm at that high target, and I make a mistake and call it bad. That's my first mistake. And the second mistake that I can make is when I call it good when it's really at that lower threshold. So I'm at the bad level, what I said I would be worried about, and I make a mistake and I call it good. It's not a perfect system. We take into account how willing we are to make a mistake hidden behind the calculation of the sample size and decision rule. But once you give me these 4 parameters, I can give you a sample size and a decision rule that meets these 4 constraints. It will call it high when it's at the upper threshold, minimizing the mistake to be less than this. And it will call the low when it's at the lower threshold, minimizing the mistake to be less than this lower level. So for this example of bed net coverage, and remember the example I gave you, the system was a sample size of 19 and a decision rule of 9. Okay? So when we were designing this system, we went in and we said, what is your definition of good bed net coverage? What are you aiming to achieve in your community? And they said, we would be happy if we had 60% bed net coverage. That's what we think is good. So if an area has 60% bed net coverage, we want to call it high bed net coverage. And I said, well, it's not going to be perfect because the only way you can do that with perfection is to look at every house and every bed. So how willing are you to make a mistake? And they said, we are willing 10% of the time to make a mistake. And mistakenly call it bad bed net coverage when it is at 60%. And then I go in and I say, well, what areas would you be worried about? What is your definition of low bed net coverage? And they said, if we see bed net coverage drop below 30%, we are really worried. Those are areas that we are very concerned about and we want to target for intervention. And I said, okay, it's not a perfect system. You're going to make some mistakes. How willing would you be to make a mistake and call areas with 30% bed net coverage as good? And they said, we would like to make that mistake 10% or less. So the benefits of lot quality assurance sampling, one is you typically can get away with smaller sample sizes because you're aiming for classification. So I am not trying to get an estimate with a tight confidence interval. I'm trying to do high and low. And because I'm looking at classification, you usually can get away with a smaller sample size. Now, smaller sample size is relative. And it really does depend on those 4 parameters. So there are systems that I've seen that have LQAS that have 1,000 people in them. Okay, and that is not a small sample size by any means. But a lot of times we can get away with smaller sample sizes. Another benefit is it requires little statistical training to implement the classifications. You know, you're just counting and comparing to a decision rule. It leads directly to program management decisions. So it really does, in my experience, support actionable data. So I give you results from a study and you know quickly what you need to do and where areas are struggling to improve. And then finally, it oftentimes is used in decentralized data collection to help understand local variation. So we'll look at this study where we see they looked at different areas and some were high and some were low. And it helps us get a better sense of where areas are performing relative to each other. I don't think that data quality across Kayonza is the same. I don't think bed net coverage across Kayonza is the same. I don't think that quality of care across Kayonza is the same. So this helps me know which health centers are doing good and which health centers are doing bad, so I can action on that and have a better understanding of our program performance. So it's useful in those settings. If you want to understand program performance, if you want to have, or if you have ideas of what actions you want to take based on an assessment, and if you want to assess variability. I will say that if your goal was to know exact levels of disease with confidence intervals, to track trends, or to look at complex relationships, I probably would not recommend LQAS. I would probably defer you to a more traditional cross-sectional study.